Committee on Health, Education, Labor, and Pensions will please come to order. Last Friday, President Trump and Secretary Azar announced a blueprint on drug pricing. It seemed to me that it was sweeping, comprehensive, sophisticated, and appeared to put patients and taxpayers first. The administration is beginning to tell us more about what they have in mind. Some are asking, and in some cases, they're asking for input from the public about some of their objectives. So it may take some time before we know what the specifics of all the proposals are. Many of the proposals appear to be in the jurisdiction of other committees, but some of the more important pieces will be in the jurisdiction of this committee, including more competition for generic drug biosimilars, over-the-counter drugs, which this committee already has taken some steps on, such as legislation we approved last month to make it easier to get over-the-counter drugs to market by modernizing the outdated monograph system, examining the relationship of the list price to what the consumer pays, that should be in our jurisdiction, policies to prevent drug manufacturers from gaming our current system. Some of these can be done by administrative action, others will require legislation. We'll be working with the administration on scheduling a hearing and other ways, such as roundtables or additional briefings with staff and with members of the committee to learn more about their proposals. The administration has already started that process. The President announced a proposal on Friday. The Secretary had a bipartisan call for senators the same day. The Department has begun briefing staff. We'll continue to make sure that members and staff know as much as we can know about the proposals. But today's hearing is the second in a series of hearings about the 340B program. For several months now, the committee has turned our attention to the high cost of health care. We've held 3 hearings on the cost of prescription drugs as a part of that, most recently with the National Academies. Like those hearings, today's hearing is bipartisan, which means Senator Murray and I agreed to it, and the witnesses are bipartisan, and we thank you both for coming. So I know senators have a right to talk about everything from health insurance to football in their 5 minutes, and often do, but I hope we can focus on this unusual opportunity to get some independent evaluation of the 340B program from the experts who we have here today. Today, I hope we can determine what's the purpose of the program. Is it fulfilling the purpose? Should there be changes in the law so the program can fulfill that purpose? Senator Murray and I will each have an opening statement, then I'll introduce the witnesses, and then we'll hear from them. And senators will each have 5 minutes to just question the witnesses. At our first hearing, we heard from hospitals, drug companies, community health centers, and pharmacies, and we learned there's a lack of agreement on the following questions. What is the total amount that Americans spend on prescription drugs? What percent of that spending is subject to the 340B discount? How much do hospitals and clinics save through the 340B discount, and on what do they spend those savings? This lack of agreement on the amount of money and how the money is spent makes it hard to properly oversee the program or to know how much of the savings hospitals and clinics receive from discounted drug prices and are used to reduce the price of drugs and treatments for patients, and how much is spent on other activities. Very well may be that most are using the savings to benefit low-income patients as intended, or it may be that the other activities meet an important public objective, but it's hard to know until we have more information. Today's hearings, we're hearing from the Government Accountability Office, the GAO, and the Department of Health and Human Services Office of the Inspector General, who have examined and published a number of oversight reports on the 340B program. We'll have a third hearing, which was suggested by Senator Kaine. We'll have that later this year to hear from HRSA, the Health Resources and Services Administration. In today's hearing, the GAO and the Department of Health and Human Services Office of Inspector General are nonpartisan federal watchdogs that issue recommendations on how federal programs could run better. In 2011, GAO found that HRSA oversight of the program was, quote, inadequate, saying HRSA's oversight is inadequate because it primarily relies on covered entities and manufacturers self-policing That is, participants ensuring their own compliance with program requirements. And in 2014, HRSA drafted regulations to define what a patient is. However, HRSA was sued in 2014, and the courts found HRSA lacked the statutory authority to engage in such rulemaking, limiting what it could do to oversee the program. The Inspector General of the Department of Health and Human Services has come to similar conclusions as GAO, including that oversight of the program has been inconsistent and HRSA lacks authority to adequately oversee it. To improve oversight, the Inspector General recommended that HRSA clarify which patients are eligible to receive 340B drugs, how hospitals and clinics can use contract pharmacies to dispense 340B drugs, and clarify other requirements on eligibility. Another concern raised by the Inspector General is that states need to have more information about the price and discount of drugs in the program to properly reimburse through Medicaid. They've recommended that there be more transparency on the price of 340B drugs to ensure states are making accurate payments. I hear often that hospitals and clinics are using the 340B program to benefit low-income patients or serve another worthy public objective. But I'd like to hear more about if HRSA's lack of oversight authority has made it difficult for us to have agreement on a common set of data about the 340B program so that we can make such determinations. Senator Murray.